All right, so we'll get started here. I'm Devin Shannon. I'm the fellow associate chair for the Ultrasound Case Series. I get the privilege to introduce one of my mentors in sports medicine who's been foundational to my own ultrasound knowledge. But Dr. Stephen Schaaf is going to be giving our case presentation today. He's an assistant professor within physical medicine and rehabilitation and orthopedic departments at the Vanderbilt University Medical Center. He helps lead musculoskeletal ultrasound education locally for the Vanderbilt PM&R residency and sports medicine fellowship. He's also actively involved nationally with musculoskeletal ultrasound education through AMSSM and AAPM&R. Today, he's going to be giving the ultrasound case series presentation on tennis leg.
All right, perfect. All right, thanks, Devin, once again for the introduction and your help through the ultrasound case series. So today I'm going to be giving a presentation on tennis leg. And so Devin had mentioned that I'm at the Vanderbilt University Medical Center, just working with both the PM&R and orthopedic department here. And so for this talk today, I have no financial or other conflicts of interest to report. As for the typical outlines for these ultrasound case series presentation, this is going to be what we're going to be following. So we'll just go through a brief case presentation, scan considerations for the tennis leg, as well as then a standardized protocol for this. And we'll go over in more detail the specific images for these protocols, and then lastly go over the report, and then hopefully we'll have some good discussion at the end. For this case, it involved a 51-year-old male who presented with acute right lower leg pain and swelling. And more specifics for the case is that this actually began with pickleball. And I know traditionally this is called tennis leg, but obviously, as we're seeing, pickleball is becoming a more popular sport. And so these quote unquote tennis legs are actually something that I'm seeing obviously very frequently for pickleball. And I think reviewing the literature, I've seen it usually be anywhere from, the number 2 injury that we're going to see for pickleball all the way down to like number 5. So something very common just because we're going to have similar mechanisms as we see for tennis. And so for this patient, it just occurred while he was pushing off with his right lower leg. And then following this, immediately developed pain and swelling along the medial calf, but he didn't know any bruising. He endorsed some calf weakness, but this was primarily due to pain, but no numbness. And then he didn't report any prior right lower leg injuries. For physical exam for this patient on inspection, there wasn't any obvious muscle deformity, but he definitely did have some mild swelling of the right calf compared to the left. Didn't have any obvious bruising, but did have an antalgic gait just because he was obviously having pain in that calf. He did have tenderness along the medial calf, really along the mid portion, and then going down to the distal portion. He still remained with full ankle dorsiflexion and plantar flexion, intact to light touch. He did have intact dorsiflexion and plantar flexion, but definitely some pain with these motions. And then notably for special tests, Thompson test was negative for a likely Achilles tendon rupture. And so, with these case series presentations, we always, ask ourselves, is ultrasound going to be useful in this scenario? And definitely for these cases of tennis leg, it should be. Number one, it can provide very high resolution imaging of the triceps surae complex, which is going to be the most commonly injured for these quote unquote tennis leg presentations. And then in addition, compared to other imaging modalities, this can allow us for a dynamic evaluation, which is going to be very critical to see if the triceps surae complex obviously is still maintaining its appropriate movement. And so typically for these scans, we're going to be using a mid-frequency linear array transducer. Sometimes, depending on patient's body habitus, you can, flip between a higher frequency transducer if you're going to be, specifically looking at more like superficial tears. Sometimes you may even need to use a lower frequency transducer, just depending on the patient's body habitus, if it's larger, especially if you're looking at the deep lower leg musculature. But typically for this scan, I'll be having the patient in a prone position, and then usually having their ankle and feet kind of hanging off the edge of the bed, just in case you need to do any dynamic evaluation. And so the protocol that we're going to be using for patients coming in with tennis leg is really going to be following the posterior lower leg and ankle. And so through the AMSSM protocols, obviously this has been outlined. So routine structures that we want to make sure to evaluate is going to be the medial and lateral gastrocnemius muscle, followed by the soleus, plantaris, Achilles tendon, and then the bursas surrounding the Achilles tendon, which is going to be the retroachilles and retrocalcaneal. And then nerve-wise, we'll be looking for the sural nerve. And then lastly, don't forget about joints, which is going to be the posterior tibiotalar and posterior subtalar joints. And then with these presentations, some of the optional structures or more advanced scans, just depending on what you're getting from their history and physical exam. Optional areas that you can scan for this within the differential could be a Baker cyst, especially if you have rupture of that Baker cyst, and then it's going to be going down into the lower leg region. Also, depending on the sport, you may involve the deep posterior compartment musculature, especially for a sport such as dancers that can commonly affect the flexor hallucis longus, but this could also involve the posterior tibialis and flexor digitorum longus. And then lastly, some patients may mimic tarsal tunnel syndrome, and so for this, you can scan the tibial nerve as well too. All right, so let's go ahead and get into the images. For the posterior leg, sometimes I feel like you can get lost if you just start with the musculature, just because ultimately there's not going to be like a bony landmark that you can go to. So traditionally for this, I'll actually start my home base wise at the Achilles tendon, especially just because you want to make sure that this is intact, which would be your biggest concern with regards to potential rupture. And so for these scans, typically I'll start at that insertion along the calcaneus, looking at the Achilles tendon in a long axis, which is pictures depicting here. And so obviously here we're not seeing any tendon abnormalities along the insertion. And then of course, for any of these tendinous structures, we're going to be wanting to look into orthogonal planes. And so for this, once again, we're going to be looking now in a short axis view, and once again, not seeing any Achilles tendon abnormalities. Importantly, though, obviously we know the Achilles tendon is going to be a very long complex, and so I want to make sure that you scan it in its entirety. And we know that typically the majority of tendon tears as well as tendon pathology is going to be occurring at that mid portion, just because poor vascular supply to this area. So I want to make sure that you continue to scan more proximally, and this is just going to be an image depicting the mid portion of the Achilles tendon, which once again, we're not seeing any tearing, and also is going to be a normal size, which was measured at 0.6 centimeters, and usually anything less than 1 centimeter is going to be considered normal for not having any type of tendinosis. And then once again, taking a look in the short axis, this is going to be depicting a scan where we're going to be going from proximal to distal along that calcaneal insertion. And once again, in the short axis, we see kind of the gastrocnemius muscles and then soleus come together to kind of converge to make that Achilles tendon. And as we're doing the scan, we're not seeing any specific abnormalities involving the Achilles tendon. But one thing I do want to note that you might see kind of more superficial to Achilles tendon is that you're actually getting some edema within the superficial tissue, some modeling of the skin in that area, which obviously we'll kind of go into a little bit more later, but could be demonstrating that there's going to be a more proximal injury just because you are getting swelling at that area. Furthermore, some of the routine structures we had mentioned, you want to take a look at the retroachilles and a retrocalcaneal bursa. For this, then the Achilles bursa is going to be superficial, and then the calcaneal bursa will be deep. And at this area, we weren't seeing any bursal distension. Furthermore, for the nerve structure in this area, we're going to be looking at the sural nerve. You're going to be finding this just lateral to the Achilles tendon. And usually you can be finding this with the lateral sural artery. So this is a picture once again depicting that sural nerve, which as we had mentioned is just going to be lateral to the Achilles tendon, but weren't seeing any nerve abnormalities at this area. And then as we had mentioned, to kind of complete, a routine scan, important to kind of evaluate the joints, especially if they're having any swelling or fluid at this area. Traditionally we're more looking at these, tibiotalar and subtalar joints more anterior, or even, lateral. But of course you can see these posterior as well too. And so taking a look at these, you'll see an image on the right screen, just visualization of how we're looking at these transducer wise. So this is going to be in a long axis. I do think this takes a little bit of, practice to kind of get used to, just because as I'd mentioned, typically we're viewing these, more anterior. So sometimes for this, you got to be, angled, but the main thing is just finding your home base along the calcaneus. And then sometimes just depending on the obliquity, you got to kind of angle it back, at that tibia. Sometimes you do have to have some toggling as well too, to ultimately optimize this image. But once you see that tibia, obviously, then you can focus on the tibiotalar joint, which we're going to be seeing in the image here, but we weren't seeing any effusion or cortical irregularities. And then, of course, then you can go ahead and evaluate the subtalar joint as well, too, where we're seeing that between the calcaneus and the talus at this area. But once again, we're not seeing any effusion or cortical irregularities. And then next, as we're kind of, moving up to that mid lower leg region, you can start to see another portion of the triceps surae complex, which is going to be that plantaris. And so as you go distally into the lower leg, it's going to be sitting just medial to the Achilles tendon, which I think is going to be the most common area that you can find this. Obviously, in some patients, upwards to 10 to 20%, they may not have, a plantaris. So just be aware of that, and you can always do a side-to-side comparison if you're having trouble, finding it. But for the plantaris, it's a fairly long tendon, but as it's going up more proximally, it's going to continually go more lateral along that medial gastroc, which is going to be deep to the medial gastroc and superficial to the soleus. And then eventually, as you go more proximal towards the knee, it's going to become its muscular portion, and then ultimately be attaching to that lateral supracondylar ridge along the femur. So it's a fairly long, muscle and tendon, but I think the easiest place to find it, if it is present, is just going to be along the medial aspect of the Achilles tendon at the more kind of distal lower leg region. And then now focusing on more of the main part of the triceps surae complex. First of these is going to be the soleus, which is going to be just deep to that medial gastroc and lateral gastroc anemius musculature. So of course, the soleus is going to be the largest of these muscles. And so as we had mentioned, sometimes you definitely have to drop the frequency to be able to see this appropriately, and sometimes take, larger, field of view to ultimately view this fully. And so the key for the soleus, obviously, is going to be, fairly deep, large musculature, but it also does have kind of separate, aponeurosis and myotendinous junctions. And so in this image here, you can start to depict some of these, not in its full entirety, but you're going to have a medial portion, a central portion, a lateral portion. And of course, any of these can kind of get injured, separately with injuries and tendon tears. Important if you are seeing any tendon pathology in that short axis, of course, then confirming it in the long axis. And so this is going to be then depicting that soleus, and we're just seeing that pinnate appearance to it, which is going to be just deep to the gastrocnemius musculature in this area. And for this patient, we weren't seeing any tendon abnormalities such as tears. Going to now focus on the lateral gastrocnemius. So once again, this is going to be superficial to that soleus. For the short axis view, we're seeing that kind of typical marbled appearance that we want to see for that muscle. And then once again, looking in the long axis view, and we're seeing the pinnate appearance, and not seeing any ultimately any tendon tears or any tendon pathology in this region. But now we'll kind of move over to the medial gastrocnemius for this patient. And obviously right away, in comparison to the lateral gastrocnemius, we're starting to see, muscle changes in this area. And so ultimately, what we're starting to see here is that not only is there going to be muscle tearing, but you're also getting involvement of the aponeurosis. And then we're seeing intermuscular hematoma between the medial gastroc and the soleus as well, that is going to be fairly significant. And so, as we had mentioned, you're going to want to go ahead and take a look at this in long axis too. And so this is just depicting that medial gastroc. And once again, we're seeing kind of tearing at that aponeurosis, and then an intermuscular hematoma just deep to it, which it's separating it from the soleus. Um, and then the key for this is that obviously with the medial gastroc, it can be a fairly long muscle tendon complex. And so making sure that you're going all the way from proximal to distal, and then specifically at the distal area, you really kind of want to focus on that aponeurosis in conjunction with the myotendinous junction of the Achilles tendon to see if it's going, down that far. And so once again, this is now scanning down distally, and we're seeing that the intermuscular hematoma is continuing, down to this area, and then continuing to see muscle tearing that is involving the aponeurosis. But as we had mentioned, one key thing as we're going down distally is that there's actually going to be a unique portion of the medial gastroc that will then be void of muscle tissue that will still be the aponeurosis. And this is known as the free gastrocnemius aponeurosis. And this then will continue to go separately and then converge with the soleus. And then this will ultimately then make the myotendinous junction of the Achilles tendon. And this is once again a very critical area to get used to scanning, and is fairly unique for the gastrocnemius. But this is a very, once again, as we had mentioned, important area and vulnerable area to get injuries. And we'll kind of go into once again why that's important a little bit later as well too. So for these injuries, important that they can be very large. And so sometimes doing either a larger field of view image or even doing a video can kind of demonstrate that. And so here we're really then seeing this injury in its entirety as we're scanning from distal scanning from proximal to distal in this area. And then you really just get a sense of how large that muscle injury is, as well as then that hematoma formation as we're scanning then from proximal to distal in this area. And for that kind of aponeurosis involvement, as well as then that hematoma, you can see that it's almost involving at least greater than 50% of that medial gastrocnemius. And then doing a long axis scan here, once again, just seeing scanning from distal to proximal, just seeing how large of involvement this injury has. But as we had alluded to, one important thing that you can do with ultrasound compared to the other imaging modalities is evaluate this dynamically. And typically for this, we're going to be doing passive dorsiflexion and plantar flexion. And this is extremely critical to evaluate to see if the triceps surae complex is staying intact with synchronous motion, or if it's becoming asynchronous, which could be indicating a more significant tear and a more significant injury. And so for this patient, so what we're doing, they're going to be lying prone. And as I'd mentioned, typically then their feet are going to be hanging off the bed. And then I'm going to be moving them passively into dorsiflexion and plantar flexion. And the key here is that we're really focusing on the end portion of the medial gastrocnemius muscle as it's going into the free gastroc aponeurosis, which we had mentioned is going to be void of muscle tissue. And then what we want to see is whether when we do that movement, whether it's going to be synchronous with the underlying soleus or not. And so as we're doing this, we see for this patient that there is going to be synchronous motion. So then that is then likely referring that the triceps surae complex, at least dynamically, is still remaining intact in that regards. All right, and then lastly, some of the optional structures that you can evaluate, especially depending on the patient presentation, could be a Baker cyst, which is going to be more proximal at that medial knee area. So for this, you're going to be really then focusing on the semimembranosus and the medial gastrocnemius tendon. In that area, we weren't seeing any Baker cysts that were present. But as I mentioned, in some patients, I may not have a Baker cyst present, but at least with a lot of fluid, but could have a ruptured Baker cyst, which may continue to kind of track fluid, more distally. So this can be an important area to scan. And then we had mentioned in the deep posterior leg musculature. In this area, you're going to be looking at the tibialis posterior, flexor digitorum longus, and flexor hallucis longus. And so this is really going to be just medial to the Achilles tendon and the plantaris in that area. And so you can scan that once again in its entirety, all the way from the mid leg down to the medial ankle in that region, and continue to follow those down individually. But we weren't seeing any abnormalities in this area. And then lastly, you can evaluate the tibial nerve, which once again is just going to be medial to the Achilles tendon and the plantaris. We weren't seeing any abnormalities in this area, but of course you can continue to follow that all the way to the posterior knee, and then all the way down to the tarsal tunnel if you're concerned of any tibial nerve involvement. All right, so that concludes the images for this case. Now we'll go into the detailed report. So this was a complete diagnostic ultrasound of that right posterior leg and ankle. The indications for this, of course, were going to be that the patient had acute right lower leg pain and swelling. For this, we had used a mid-frequency transducer. And then the findings for this report really to focus on is going to be that medial gastrocnemius muscle. And so as we had seen for this patient, they had an aponeurotic tear that affected over 50% of the total gastrocnemius. And there was a significant hematoma formation between the gastrocnemius and soleus. And then as we alluded with the dynamic scan during passive and passive dorsiflexion and plantar flexion of the gastrocnemius, that there was synchronous movement between that gastrocnemius and soleus in the same direction. And then for the rest of the scan, as we had mentioned in the protocol, there were not any abnormalities seen. So ultimately, the conclusions then for this report is that there was a medial gastrocnemius tear, a type 2B injury, and we'll go into that just briefly here in a minute, with an intramuscular hematoma. And so just briefly, this is not going to be a comprehensive, talk about this, but just did want to mention kind of a landmark article that everyone should be aware of for these injuries. And this is going to be the ultrasound classification of medial gastrocnemius injuries. This was from Carl Pedret, who's an expert out of Spain on musculoskeletal ultrasound, especially for these gastrocnemius muscle injuries. And so in 2020, he came out with an article. It really goes into this in great detail that I'd recommend everyone read. And so this really kind of breaks it into different subtypes, which does have importance for injury severity and return to play, and really broke these into kind of 5 different types. So type 1 is just going to be involving the muscle fibers. So this is going to be a myoaponeurotic injury. Type 2 is going to be involving the aponeurosis. And so there's a 2A and a 2B. Basically, 2A is going to be less than 50% of the aponeurosis, and 2B is going to be greater than 50%. And then higher grade injuries is going to be type 3, where it involves that free gastrocnemius aponeurosis. And then type 4 is going to be a combination of both an aponeurotic and free gastrocnemius aponeurosis injury. And as we had alluded to, the higher number from these injuries is going to indicate a more significant injury, and usually a longer return to play for these athletes and patients. So ultimately, then for this case, this patient, just because of the large size of the hematoma, and underwent serial ultrasound guided aspirations of that hematoma, ended up doing a total of 3, 2 weeks apart. And then eventually after this, the hematoma stopped reoccurring. Ultimately then was immobilized in a cam boot for around 2 weeks. And then following this, followed a formal physical therapy program. And now this patient's around 2 to 3 months out from the injury. Clinically, he's feeling a lot better, no longer really having any symptoms, especially just with daily activities and weight bearing. And so he is beginning to wean back to exercise and sporting activity at this time. So the key points I just want to make sure everyone kind of gets from this talk, especially for evaluation with ultrasound of tennis leg, is just make sure that when you're going through this, obviously, we had mentioned the standardized protocol, but the real key things, then for the report that you want to follow is just make sure you document the specific anatomic injury, location, of that triceps surae complex. And then if it is involving the medial gastroc, just make sure that you articulate, is it involving the muscle, the aponeurosis, or is it also involving that free gastrocnemius aponeurosis as well too? is there intermuscular hematoma formation between the gastrocnemius and the soleus? And then lastly, and very critical, is just make sure you do a dynamic evaluation as well too, looking at whether there's synchronous or asynchronous movement of the gastrocnemius and soleus when you're doing that passive dorsiflexion and plantar flexion. So then that will conclude today's talk. So I'll just go ahead and open it up then for any questions or discussion.
Stephen, Brendan Betcher here. That was a great presentation. These are always satisfying injuries to scan, right? You get like immediate feedback. The patient can see exactly what's going on. And so they're always a kind of a fun one to review with them. Just a couple of thoughts I have, on this particular diagnosis. I think, one of the questions that you brought up right away was like, do we need ultrasound to scan this or not? And I tend to fall kind of along your lines with this. I tend to scan most of these that come into my clinic, and exactly the point that you made towards the end, looking at like what is, is there any disconjugate motion present with movement of the calf? And I guess one of the questions I have for you is like, what do you do differently if you see disconjugate motion? Because I have, my thoughts on it, but I haven't seen anything real definitive on like a good management protocol differentiating patients with synchronous motion and asynchronous motion. And so I just wanted to ask you, like, how do you manage these differently if you find that? Because I think that's an important part.
Yeah, no, for sure. Yeah. And once again, as you alluded to, I don't think there's any standardized protocol right now. I guess first and foremost, if I do see asynchronous motion, though, I'm already setting expectations, I think more for the patient, like, hey, this is going to be a longer, term injury when we're looking at it. As far as, return to play and recovery, it may, it hasn't really affected, I guess, how long, I'll mobilize them. Usually I'm still, I guess, a little bit more quick to kind of get them weight bearing as tolerated on that lower extremity. So usually about 2 weeks is the longest I'll go for a mobilization, just because obviously they can start running into other issues with it. But I guess the only thing is, if you were more concerned with that asynchronous motion, do you boot them for a longer period of time? But I think in general, it just immediately changes, though, my prognosis, for that patient. And then the conversation that I'm having with them about how long it's going to take to recover from this injury, especially if they're in season and already starting to get an idea of like, hey, if I'm seeing asynchronous motion, I'm starting to get concerned that this is going to be, probably closer to at least like a 2 to 3 month, recovery from that standpoint. And obviously could even be in longer than that.
Yeah, certainly. So I actually do manage them a little bit differently. I think the expectations is one thing, and I know this isn't to talk about that, but I think that's everyone's own individual clinical judgment right now in the absence of any great guidance. I think understanding that is an important part. And then some of the other things that you mentioned, I just wanted to highlight a little bit. One of them is like having the protocol of like what you're actually looking at, I think is really helpful. We all want to just go straight to the medial gastroc because we think it's that. But you pointed out, one of the things that we sometimes see with these is like a plantaris tear. And with a plantaris tear, you see that kind of tubular edema hemorrhage sort of coming through that same region. And I think it's really important to identify that, because that, once again, from a prognostic standpoint, has an excellent prognosis and a very quick recovery prognosis. And so I think kind of evaluating that whole structure, from muscle, down to the tendon distally is really important. Baker's cyst ruptures also can present very similar to this sort of injury. Oftentimes these patients are already improving before they get into the clinic, but certainly something you want to evaluate. Do you see a bunch of edema and hemorrhage because someone ruptured their Baker's cyst, or is it really because they tore something? Looking at, you mentioned also like the medial kind of deep posterior compartment. So posterior tib ruptures can also produce some calf pain. And so patients that have, a progressive flat foot deformity or have asymmetric, kind of hindfoot valgus and pes planus are someone that you should think about really looking at that structure. And those, are sometimes really, really obvious with a lot of fluid, and sometimes they're not. the ones that have kind of these attritional tearing, and so that kind of like differential diagnosis. And then I think the last two things I want to comment on. One is soleus ultrasound, and soleus is just the ultrasound of the soleus muscle is not very sensitive, and so we can certainly miss injuries in that area. So especially in our athletes, the soleus, we think about the gastroc being a prime mover for like explosive movements. It's actually still the soleus, even though we think about the gastroc being kind of that quick twitch muscle. And so if you're highly suspicious for injury to the calf muscles, and you don't see anything in the gastroc ultrasound, and kind of your differential diagnosis screen is negative, that's someone that you probably should think about getting an MRI on, because that's something that we miss really commonly on ultrasound. And then the last thing is, these patients, when they come in like subacutely, I always try and look to make sure I don't see there's any evidence of a DVT as well, because I've seen a couple of athletes who have had gastric tears and older adults, gastric tears that then also have a co-development of a DVT. And so just kind of keeping that protocol in the back of your head as well. And that's certainly something a lot of us are not super comfortable with from a scan standpoint. I know that's something that we're doing at the advanced course at AMSSM this year. So anyone who's interested in kind of learning more about that should think about that. But yeah, those are, I think, these are fun scans, and you did a great job on that, and great presentation. And I think your report exactly highlights, what we want to convey to any referring providers as well.
Yeah, thanks, Brendan. Yeah, I appreciate all those comments. Yeah, one thing I would, piggyback after is just the plantaris tears. I mean, those can actually be fairly tough. And this was even in this case, I think the critical part for scanning those, if you're, having difficulty seeing that versus, just the medial gastrocnemius injury is really actually the short axis scan, and especially then going from proximal to distal, just because you can see in this case, if we go back through that video, you can actually see that hematoma actually still kind of pushes down that plantaris at that area, just because it's developing between the medial gastroc and the soleus. And so I think those short axis views, if you're having trouble to figure out, is this involving the plantaris or not, really that short axis view is helpful, because you can see that then going from lateral to medial, which should still then remain intact. So.
Hi, this is Doug Hoffman. Great presentation, Stephen. And like both of you and Brennan, we tend to scan all of these both for prognostic. But I do want to ask a question, because I would say that more of the calf injuries that we see are in occupational or non-athletic population. Do you, either Brennan or Stephen, do you routinely in the non-athletic population aspirate a hematoma acutely?
I do.
Mm-hmm.
Yeah, I would say most of the time, if I see it and I think it's significant enough, I would do it. I think just me, I feel better about the potential healing of it, that it's going to heal more appropriately and will be less prolonged. And I guess too, I've talked to a few different people as well too. I mean, this will be more in the athletic, I guess, population, but how often you actually bring these patients then back to do the serial aspirations. Clinic setup wise, I have it where it would be a little bit tough to be bringing them back like every few days, but I think in some may do that. But at least for me, I'm usually about a week, maybe at quickest, and then every 2 weeks. That I'll continue to kind of reevaluate these, and these can be, long time that you're continuing to perform these serial aspirations. But at least for me, I feel that if you decompress that hematoma, that you're getting more, convergence of that triceps or A complex going together, that it may have a better chance of healing appropriately. Maybe that just makes me feel better, but in general, that's my thought of aspirating then these hematomas, and then also just removing that blood, which I think can be, an irritant not only to that area as it's continuing to heal as well too.
Yeah. Again, we tend to scan these for prognosis. I mean, obviously to define the injury and prognosis. I know Ryan was on, he's not on right now, but Brennan or Stephen, any experience with PRP or PPP and these injuries and attempt to lessen downtime and also promote less scarring and more just healing of tissue?
Doug, similar to you, I would say, probably 80% of these that I see are in the non-sports population, or the recreational sports population is probably a better way to put it. So kind of the weekend warrior population. And so most of them are not interested in doing anything other than maybe aspirating the hematoma, which I think is reasonable. I know Ryan does use PRP and or PPP for the tendon and or muscle based types of these injuries. I don't tend to do a lot of that in my practice. Most people recover just fine, and if there isn't a major timeline, knocking off a week of recovery is probably in my eyes, probably not worth the expense in the absence of any great evidence of like substantially better scar tissue remodeling and elasticity and things like that at this point.
Yeah, I mentioned that because I have a patient who has a previous, more advanced calf injury, and now he has chronic problems. And he's young and he wants to be more active, and it's a real problem. Clearly he had a medial gastroc aponeurosis injury. And so that's what made me think, in more advanced pathology, something to think about. And at least it's got me thinking of, along those lines. And he was a recreational, athlete. So again, just some food for thought about maybe in those more advanced grades, because they can result in significant disability, at least a percentage of them.
Yeah, I think some of the, obviously with Ryan's data and everything as well too, it definitely seems like platelet poor plasma is seeming more beneficial for these muscle, injuries. At least for me, I mean, if this isn't a high-end athlete, I'm not jumping to it right away. I think if you have access to it, of course, you then may go ahead and do that, just because it has minimal downside, to it, for the higher end athletes if they have access to it. But in the more, recreational athletes, usually what I've done is just allow the body to try to heal naturally, from that regard. And I feel like if they're having a more prolonged recovery, you're getting to 2 to 3 months and they're just feeling like they're plateauing, I think then that may be at the point that I would start to include, the platelet poor plasma. And usually I've told patients, but surprisingly, the majority, get to that kind of 2 to 3 month mark if it is a major injury and they feel okay. And, they're getting closer to, the 95%, which is usually about all they need to then get back to the exercise and sport that they want to do. But obviously, I feel like if they started to kind of plateau at that point, that's when I would start to include it in the treatment, algorithm.
Yeah. And just from an academic point of view, there was an interesting article that came out a few years ago in skeletal radiology, Philippe Myers, and he looked at the plantaris tendon, and when he found that there was, quote, normal adhesions where it crosses the distal fibers of the medial gastroc and soleus. In other words, it gets sandwiched in there. And when there was adhesions, he postulated that was involved in the mechanism of medial gastroc tears. And he tried to correlate that, using cadavers, that how the pull of the plantaris, when it is adhered to either the gastroc, soleus, or both, again, and then he kind of correlated a few injuries right at that location. So just more academic.
Right. And then I think the only comment that I really got, Dan Cushman was popping on, and he also mentioned just for the treatments as well too, that compression sleeves or socks, he's found very helpful with return to play, particularly in the runners, which I would agree with too, as well, if they're continuing to have some swelling. All right. Well, unless there's any other comments or questions, I really appreciate everyone jumping on for this presentation this morning and discussion, about these injuries. So thank you again.